Today's module is on sacroiliac joint injury, sometimes called SI joint injury. The SI joint, as you know, is the joint between the spine and the pelvis, and it can be injured with trauma, such as a motor vehicle crash, fall on ice, fall down stairs, fall off a bicycle. Generally, you need some specific injury for the younger patient to have SI joint problems. For the older patient in their 50s or 60s, this is not as true, and there are some very rare conditions such as ankylosing spondylitis where there can be inflammation of the SI joint. The important thing about this diagnosis is it is fairly straightforward to make, but you need to do a very careful history and physical exam. Treatment can often be gratifying, including at times using something as simple as a good sacroiliac joint belt if patients do not respond to other initial treatments such as spinal manipulation, mobilization, and that sort of thing. We will discuss this more in the history and physical examination portion. Key to remember about this diagnosis is that it's almost always traumatic in the younger patient. People don't get an SI joint injury picking something up in their garage. They get it from falling on a hard surface, falling off a bike, in a car crash, that sort of thing. In fact, people who've been in motor vehicle crashes, more often the right side is injured more than the left because that's where a lot of compressive force has been transmitted across the leg into the femur and then into the sacroiliac joint. In terms of the anatomy, there's this sacrum hiding behind these blue ligaments, and there's the ilium, sacroiliac, spine, pelvis. It's the spine-pelvis joint. There's a tremendous amount of upper body weight that is transmitted through this joint. And this joint is held together by these ligaments shown in blue here. These ligaments can get torn in a crash or on a fall. The key to remember, and it's similar to the facet joints that I've discussed previously, is that the MRI scan of the lower spine, of the lumbar spine, will show these joints, the sacroiliac joint, but it won't show injury to or pain from the joint. A lot of times, a patient's coming from their primary care provider with an SI joint MRI that's normal. And unless there was a major pelvic fracture, it's supposed to be normal. I don't really rely on imaging for this diagnosis. I rely on history and careful exam. Here's the front of the joint shown here. Sometimes in an older patient, you might find SI joint injury without trauma. But again, the younger patient, you don't see that. On physical exam, patients typically will have some pain when they're leaning forward. In terms of history, they often don't like to sit. And I'm not quite sure why that is, but it sometimes can be confused with discogenic or disc herniation pain. When we do the physical exam, I'm going to have Jennifer stand here. Some practitioners will actually look at whether there's an asymmetry in mobility between the right and left side. So the patient brings their leg up, and they can see that there will be a change in the mobility of the right versus the left, the so-called. Well, there are a couple of tests here, the Gillette's test and that sort of thing. I don't really get into that. I don't have really good manual skills. I rely a lot on history. In terms of when the patient's lying down for physical exam, there are a few things that we'll find. One of the things is we're going to rule out competing diagnoses. I've mentioned elsewhere that the patient might have a pseudo-radiculopathy or a sciatica from SI joint injury, but not with neurologic findings. And so we're going to do all kinds of neurologic testing to make sure there's not neurologic weakness. This part of the exam, usually straight leg raise, fairly well tolerated. Hip external rotation often causes pain in that area. And this is called a Patrick's test. It's not 100% reliable, but it's one more clue. And again, we're also using this to rule out hip arthritis. Otherwise, most of the neurologic exam is unhelpful. When we do have the patient lying on their side, if you could do that, please, Jennifer. The one thing you'll find is that the hip abductor strength test for gluteus medius and minimus, this often is both painful and weak for the patient. And it's because you're stressing the sacroiliac joint. But otherwise, the neurologic exam is pretty reassuring. One of the things that really has helped my practice in terms of sorting out the SI joint from other injuries is I have the patient try this belt on while they're in my clinic. I don't get any kickback from Dr. Sarola, who's actually a chiropractor who developed this. But it's a very helpful brace for my patient. I'll let you put it on, Jennifer. But you put it low. You put it below the spine. And the key about this brace that I've liked over the other braces is it has these sort of outriggers that allow you to compress the joint even further. And if patients have SI joint injury, they will almost immediately say, my gosh, that really helps. They'll feel like somebody finally has found something. And actually, if you retest things like their hip abductors, you know, where I was pushing down on the hip, it's often immediately stronger for the patient. And so this is almost a diagnostic tool for us. If it does help right away, we often prescribe it as well. In terms of what can be done for this disorder, a lot of more conservative care, spinal manipulation, mobilization, physical therapy, dry needling, all of that can be done. If the patient is still not improving, in our clinic what we would do is we would do an injection into the sacroiliac joint and the ligaments. And if they are feeling good from that diagnostically with lidocaine, for example, anesthetic, then we have the patient come back and we do platelet-rich plasma injections, which tend to heal up these ligaments and cause a new inflammatory but helpful reaction. Women patients tend to get this much more than men do in the setting of trauma, again, because women generally have more hypermobility, generalized hypermobility than men, possibly for evolutionary reasons. Those who were not hypermobile 50,000 years ago didn't survive childbirth.